Hello everyone, welcome to my channel. In today's lesson, we'll delve into another essential topic, central venous access devices. These are commonly known as CVADs, and they refer to devices that are placed in a large vein in the body to provide either immediate access or long-term access into the bloodstream. The catheter's tip is carefully positioned either in the lower third of the superior vena cava or in the inferior vena cava at the level of the diaphragm if it is placed femorally. By the end of this video, you will be well equipped to understand what CVADs are, describe their clinical indications, differentiate between the various types of CVADs, and learn how to perform proper care and maintenance of CVADs, which is very important in ensuring their safe and effective use in clinical practice. So let's get started. A central venous access device may be inserted for various reasons. For example, central venous pressure monitoring or infusion of certain drugs that are vesicants, such as chemotherapy, irritants, such as cloxacillin, or solutions with very extreme pH values, such as vancomycin. Chemical damage to the endothelial lining of our veins can result from administering these irritating medications and solutions, bearing in mind that that inner layer, that tunica, is only one layer of endothelial cell. We may also need a CVAD inserted because there needs to be administration of total parenteral nutrition or TPN and other hyperosmolar solutions, or administration of incompatible medications simultaneously, or administration of multiple therapies, for example, vasopressors, transfusion, maintenance fluid. They may also be inserted if it is that the patient just has very poor venous access and they're having multiple unsuccessful attempts as determined by maybe the physician or the vascular access nurse. It may also be inserted if the patient is hemodynamically unstable and may need frequent blood draws, for example, in the context of DKA or starvation, diabetic ketoacidosis, hemodialysis access, or to provide access for transvenous pacemaker or pulmonary artery catheters. There are various types of CVADs, and it is very important that we know what type of catheter the patient has because the care and maintenance for each will differ. If it is that the type of CVAD is unknown, the MRP will need to order an X-ray to verify the type of device that the patient has and confirm placement of a catheter tip. There are two CVAD type classifications, short-term CVCs and long-term CVCs. Short-term CVCs are also called percutaneous venous catheters, and then long-term central venous catheters are broken down into three different types. We have our portacat or implanted venous access device. You will have your peripherally inserted central catheters and then the tunnel catheters. If it is that CVAD tip will have power, then that tells the CT lab that they are able to use it with their power injector. Other examples of short-term catheters include multiple lumen short-term CVCs, percutaneous introducer, or temporary hemodialysis catheters. Percutaneous central catheters are also known as short-term CVCs, non-tunnel CVCs, or percutaneous sheet introducer, which is not shown here, but you will know that it's a PSI because you'll see the pulmonary artery catheter and the introducer valve. These are normally inserted, and by these I mean the percutaneous central catheters are inserted for short-term use, up to a month, if not less, and they can be placed subclavian, internal jugular, or femoral. Femoral is often shied away from because it is associated with higher risk of infection, thrombosis, arterial cannulation, and is also contraindicated if it is that the patient is going to be needing parenteral nutrition. If it is that your patient will be having or needing a CVC for more than 2 weeks, then the medical team may need to consider referral for a more long-term CVCs. Femoral CVCs that are inserted under emergency circumstance are normally changed or recited within 48 hours, and of course, follow your own hospital policies. PCCs are very, very good. They can be inserted quickly and at the bedside, and also very easy removal. You can have multiple lumens, multiple therapies. There is a lower initial cost that is associated with percutaneous central catheters. However, they have the highest rate of catheter-related bloodstream infection. You'll require routine sterile dressing change for similar to other CVADs. Patient self-care is quite difficult. For example, and especially they have the femoral PCC. Patient activity may also be hampered or decreased, and as with other CVADs, external catheter breakage is possible. The percutaneous sheath introducers are more often used in your ICUs or your CCUs. So we'll briefly talk about the percutaneous central catheter that is displayed in this picture, a triple lumen short-term CVCs. The lumens are clearly labeled, and they are labeled as distal, median, and proximal to denote or reflect the three internal exit points. The distal lumen is 16 gauge, and the median and proximal lumen are 18 gauge. There are staggered exit points or ports, which reduce the risk of mixing incompatible drugs and solutions that could precipitate. On the hubs will be the maximum flow rate, and pressure injection information will be clearly marked. Additionally, the white lumen is the proximal exit point, the blue lumen is the medial exit point, and the brown is the distal exit point. So this just gives an example of a full-length catheter as well as the multi-lumen configuration. And you'll also notice your delta wing and your staggered exit sites. For percutaneous central catheter maintenance, the caps are changed every 6 days and after blood draws or as needed. And for dressings, it's changed 24 hours after insertion, then every 7 days. And if it is soiled or loose, of course, you'll be changing it. For percutaneous central catheters, we are flushing and locking with 10 to 20 ml of normal saline per lumen. And we're always flushing with 10 ml or larger syringe all the time. If it is that you're initiating an infusion, you'll want to flush that lumen with normal saline prior to connecting your lines. If any lumen is in use, you'll flush it per shift when you're stopping an infusion, pre and post administration of any intermittent medication, and post blood sampling, you'll always flush with at least 10 ml of normal saline. If it is that your lumen is dormant, you're not using it, you'll flush it every shift. So now we're going to talk about peripherally inserted central catheters, or PICCs. And a PICC is a small gauge catheter that is inserted by venipuncture into one of our large superficial veins of our upper limb. Now, this can be the basilar vein or the medial basilar vein. It can be the cephalic vein or the medial cephalic vein, and it's inserted at or above the anterocubital space and then advanced until the tip is positioned in the lower 1/3 of the superior vena cava. These catheters will measure approximately 40 to 60 centimeter, but they are normally individually sized once they are inserted. PICCs are ideal for patients who require IV therapy for more than 6 days. However, they can last for up to a year, bearing in mind that they do also carry the risk of bloodstream infections. Peripherally inserted central catheters or PICCs are available as single lumen PICC, double lumen PICC, triple lumen PICC, and then they are further classified as valved and non-valved. The valved portion will refer to the presence or absence of a clamp. Open-ended PICCs or non-valved have clamps, as you can see here, and then closed-ended or valved PICCs do not have clamps. PICCs are normally inserted with power technology so that they are able to be used also for CT. Physicians can insert PICC, or radiologists or certified nurses can also insert PICCs. So for PICC care and maintenance, caps are changed every 6 days after blood draws or blood sampling and PRN. Dressing changes. Of course, you're going to be changing the dressing PRN if it is ever soiled or loose. Also remember that you also need to clean the insertion site with either 2% chlorhexidine or 70% alcohol swabs. You'll be changing that initial dressing 24 hours post insertion, and if it's a gauze dressing, it's changed every 48 hours. Now, the transparent dressing that you will apply will be changed every 7 days. Another nursing intervention that you'll need to do when it comes to PICCs is that you need to measure the catheter length at the initial dressing change, and you'll be measuring from the insertion site to the tip of the winged manifold, and you'll do this measurement every shift. Another measurement that you'll do is measuring the circumference of the upper arm every day and compare it to the baseline. If the patient ever reports that their arm is swollen and painful, there may be a concern that a blood clot has been formed in that vein, otherwise known as a thrombosis, and this is one of those serious complications when it comes on to PICC lines. For your closed-ended or valved PICC, so these are PICCs that do not have clamps, you will need to flush each lumen with at least 10 to 20 ml of normal saline. If it is that the lumen or the PICC is in use, you'll be flushing every shift whenever you are stopping an IV infusion and also after blood sampling. If it is that your lumen is not in use, you'll flush it every 24 hours. Open lumen or non-valve PICCs require an additional step. You'll need to flush each lumen with at least 10 to 20 ml of normal saline. And if it is that the lumen is not in use, you'll need to heparin lock it every 6 days, and you'll do this by flushing it with 300 units or 3 ml of heparin per lumen that is not in use. If it is that a lumen is in use, you'll flush it with normal saline every shift whenever you're stopping an IV infusion and after blood sampling. Tunneled catheters. So this is a central venous catheter whose proximal end is tunneled subcutaneously from the insertion site, and then brought out through the skin at an exit site. This type of central venous catheter is introduced into a central vein using percutaneous venipuncture or a cut-down approach, which involves making a surgical incision into a superficial blood vessel to facilitate catheter insertion. Venous cut-down is a surgical procedure where a physician will directly analyze and visualize your vein while they are placing that cannula. Tunneled catheters can be either cuffed or non-cuffed. Non-cuffed tunneled catheters are used for emergencies and for a short period, typically under 3 weeks. Your tunneled or cuffed catheters are able to last for much longer than 3 weeks, and the catheter is secured by a cuff. Tunneled catheters can have single, double, or triple lumens. Some examples include the Hitman, the Broviac, or permanent hemodialysis catheters such as Permcath, Hemosplit, or Equistream. These tunneled catheters that do have cuffs, normally the Dacron cuff, where they could be 1 or 2, and these are located 3 to 5 inches above the skin exit site. These cuffs serve to anchor the catheter by becoming embedded in the surrounding skin, and they act as a protective barrier against infections. Now, in the context of hemodialysis catheters, the red opening will be used to draw blood from your vein and out of your body into the dialysis pathway, while the blue opening will be used to allow cleaned blood to return to your body. Now, it's not represented here, but some of these newer cuffed tunnel catheters will have an additional lumen that's called a pigtail, where as maybe the floor nurse, you'll be able to use that lumen to specifically get your blood work from. Normally, these hemodialysis catheters are accessed by the hemodialysis team, or if you're in the ICU, and you're also able to use these. But normally, if you're on the floor, you won't be accessing them. So a tunneled catheter may be inserted for medication administration, including those vesicants or delivery of total parental nutrition, as well as administration and sampling of blood or blood products and hemodialysis. For tunneled catheters, the caps will be changed every 6 days after blood draws and PRN by the hemodialysis nurses. In terms of dressing, the dressing is changed 24 hours after insertion and then every 7 days until the exit site is completely healed. And once it is healed, a dressing is normally not required. A newly inserted tunneled central venous catheter will have 2 insertion sites, an upper insertion site and a lower insertion site. The upper insertion site is secured with sutures and requires application of a securement device until it's well healed, and healing will take place 7 to 10 days. Another important factor to point out is that these insertion sites should be monitored for signs of infection, including redness, warm to touch, or purulent drainage. And if, as the nurse, you notice any of these, you are going to consult with the physician so that the patient can be evaluated and treated appropriately and promptly. And this is an example of a tunneled hemodialysis catheters. When it comes to care and maintenance for these specific catheters, there will normally be orders from nephrology. And as I mentioned before, the red catheter is normally to remove the blood from the body for dialysis, and then the blue returns it. So when it comes to tunnel catheters, as mentioned, they'll primarily be cared for by your hemodialysis nurses. If it is that it does have a dressing, you will replace the dressing if it ever becomes soiled, loose, dampened, or it's no longer sticking to the skin. In terms of flushing, you'll flush with a flush that is 10 mLs or higher, and the pressure should not exceed 25 pounds per square inch or psi. And when it is that you're flushing these catheters, you're also needing to observe if there is any extravasation, swelling, or the patient complains of burning, pain, or discomfort. And if any of these occur, then you need to notify the physician and not use the catheter. Additionally, you have to ensure that any de-access to lumen is flushed per policy, and always use turbulent flushing and positive pressure when you are flushing. If it is that the lumen is not in use, it will be heparin locked if that's one of your hospital policies. And if it's in use, your dialysis nurse will flush it every shift once they have stopped the dialysis or an infusion that they may be given, and also after blood draws. The final type of CVAD that we're going to be looking at is the implanted vascular device, or implanted port or portacath. An implanted port or portacath is an implanted vascular access device that is usually placed under the skin and consists of a small vascular access port that is attached to a thin, flexible catheter. The distal end of the catheter, when in place, is located at the junction of the superior vena cava and the right atrium. These ports can stay in place for 6 months or longer. They can be used for medication administration, such as chemotherapy or antibiotics. They can be used for administration of IV fluids. They can be used for blood transfusion. They can be used to administer TPN or total parenteral nutrition, and they can also be used for blood sampling. There are some ports as well that can be used for high-speed injection during CT scans or MRI tests, and these ports will be called your power injectable ports. The port section of the device will of course lie under your skin 2 to 3 centimeters below your collarbone, and the nurse will be able to feel a triangular shaped bump under your skin where the port lies. The middle section of the port is called the septum or access site, and it is made up of a self-sealing rubber that will hold that port needle safely in place. These implanted ports must only be accessed by non-coring point needle. The septum will have 3 palpation points where you'll be able to feel or demarcate when it is that you're trying to access this device with the non-coring needle. These ports can also be single chamber or dual chamber. Each chamber must be managed as a separate lumen in the case of an IVAD with more than one septum. When it comes to portacath care and maintenance, you are changing your caps after blood draws, PRN, and anytime you are inserting a new Huber needle or a non-core needle. For dressing change, you're only going to be changing the dressing if it is that it's accessed. So you'll change the Huber or non-core needle and that transparent dressing every 7 days. When it comes to flushing and locking, you're always going to be flushing with 10 to 20 mLs of normal saline, and you'll lock with 500 units or a 5 ml syringe of heparin. If the portacath is not accessed, there will be no needle and no dressing. And before deaccessing, you will heparinize it or heparin lock it, and this will last for 20 days. If it's access or for intermittent use, you'll flush every shift whenever you're stopping an IV infusion and also after blood draws. For a continuous infusion, you'll flush every 12 hours. So of course, we cannot talk about CVADs or central venous access devices without talking about central line associated bloodstream infections, which are very serious infections that can lead to increased hospital stay, increased case cost, and mortality and morbidity. And any kind of healthcare associated infection is a cause for concern. And as nurses, some ways that we can ensure that we are reducing the risk, if not eliminating, is by ensuring that we are always washing our hands. So whether it be that we're washing our hands with alcohol-based or waterless hand cleaner whenever we're caring for central line. So before and after palpating the catheter insertion site, before and after inserting, replacing, or adjusting the dressing, and during palpation or insertion and application of antiseptic, we are ensuring that we are making sure that we're washing our hands. The next way that we ensure that we're reducing disinfection is by using chlorhexidine 2% skin antisepsis. So you can either prepare the skin with the chlorhexidine 2% in 70% alcohol swabs, and you're going to use a friction scrub for at least 20 seconds. Another way that we reduce these infections is by ensuring that our tubings are changed per policy. So the hospital will have a certain policy when it comes to changing your tubings, and we'll talk about that after this slide. Another way in which we reduce these infections is by ensuring that when it is that they are being inserted, that the doctor or physician follows strict aseptic technique. Site selection is also an important factor because there are certain sites that are associated with higher infection rates than others, for example, the femoral site. Using aseptic technique for accesses and changing needleless connections. Always remember to scrub the access port or hub immediately prior to use with an appropriate antiseptic, and removing any unnecessary lines. Other important points before we finish this lesson is that if it is that the patient is getting TPN, there should be a dedicated lumen. Additionally, your TPN bag set should only last 24 hours. The lipid set, 24 hours, and this can be based on hospital policy because there are some hospitals where the lipid set will only be up for 12 hours. Amino acid set, 24 hours, or whatever your hospital local policy is. Blood tubing changes. So you'll need to change your blood tubings every 4 hours and or after administration of 4 units. You'll also need to change the tubing if it is that you will be infusing lipophilic medications and continuous propofol infusions every 12 hours. So always remember, propofol tubing should be changed every 12 hours because of the lipid component that is in the propofol. Once again, thank you very much for sticking around to listen to this lesson on central venous access devices. If it is that you did enjoy this lesson, please leave a comment. What are your hospital policies? Subscribe and share with someone who you think may benefit from this video. You have a good day.